Well, hello, everyone. Welcome to another Society of Pediatric Echo Speed webinar. I'm Shivani Patel, co-chair of the Education Subcommittee, and tonight our webinar is on RV imaging and Tetralogy of Fallot. As you know, these speed webinars are 30 minutes long, and also a reminder that SOPE members can now get a half a CME for attending this today. We would also like to thank our institutional sponsors, Lurie Children's, Cincinnati Children's, Lucille Packard Children's at Stanford, Nemours Children's Health, and Seattle Children's. If your institution is interested in being a sponsor, please email Tara Foy at the email displayed on the slide. And after tonight's speed session is over, mark your calendars for your next speed. And before we head into the summer on coronary imaging on May 23rd at the same time. I'm going to now hand it over to my co-chair, Jen Kovu. Jen, take it away.
All right, a few housekeeping rules for tonight's webinar. Welcome to another SOAP Speed. The max that this session will be 4 to 5 minutes, but we usually end at 30. So participants are muted upon entry, and so each speaker will have their talks, which is around 10 to 12 minutes each. And after the second speaker, we will then proceed with the Q&A. Please type your questions on the chat box or raise your hand during the Q&A, where you will be unmuted to ask your questions. So now we would hand this over to our moderators tonight. Dr. Shivani Patel from Lurie Children's Hospital and Dr. Jenna Keelan from UT Southwestern.
Hi, everybody. Welcome to SOAP. So we are, in the interest of time, going to get started with Dr. Alisa Arunamata's talk on RV imaging in Tetralogy of Fallot. She's a pediatric cardiologist and clinical associate professor at Stanford. She's also the director of the acute cardiac care unit over there and the fellowship program director. Her focus is on refining and assessment and contribution of RV in disease and health. So take it away.
Awesome. Let me share my screen. Thank you so much for that introduction. Thank you, everyone, for inviting me to speak tonight. So my name is Alisa Arunamata. I'm a pediatric cardiologist here at Stanford, and I've been asked to speak about echo imaging of the right ventricle in Tetralogy of Fallot patients. These are my partnerships listed here. And I'll start off by saying that we say this often, but the right ventricle has long been the forgotten ventricle. And we often remark about how difficult the right ventricle is to image by echo, with its complex morphology and its relatively thin wall with coarse trabeculations. But we do know that RV performance is critical in many disease states that we encounter in pediatrics, the obvious being pulmonary hypertension, cardiomyopathies, and of course, congenital heart disease. So today we're going to quickly review RV morphology and how it relates to maladaptive remodeling and disease, limitations of the standard parameters we use to assess RV function in our daily clinical practice, and advances in imaging that we may be able to incorporate into our clinical decision-making, particularly in our population of Tetralogy of Fallot patients. Most importantly, Siddharth Tierney told me that I'm supposed to do this in under 12 minutes, and I always do what Siddharth tells me to do. So my job here is to hustle. So as we look at the right ventricle, we know that the 3D organization of myocytes differs between the right and the left ventricles, where in a healthy right ventricle, most myocytes lie in a longitudinal orientation. With that, we can also observe that the right ventricle contracts in a typical pattern: motion of the free wall towards the septum, longitudinal motion of the base towards the apex, and bulging of the interventricular septum into the RV cavity, which is different from the circumferential and radial contractions that happen in the left ventricle with the associated rotational motion and twist. Studies have also shown that the right ventricle is very limited in its ability to respond to abnormal hemodynamic loading, particularly increased pressure loading. And the expression of genes involved in RV adaptive, or should we say maladaptive remodeling, is different than in the left ventricle. Our own Sushma Reddy has been exploring this here at Stanford for some time. And you can see that the expression of genes, including FGF, is higher in patients with RV hypertrophy compared to LV hypertrophy. Endogenous FGF signaling typically promotes apoptosis. Similarly, our team has discovered a higher expression of transforming growth factor beta receptors in RVH, which promotes cardiac fibrosis. All of this contributes to the RV being prone to fail under chronic pressure loading conditions. Besides RV hypertrophy, RV dilation is often the first sign of RV pressure and volume loading and can reflect underlying RV dysfunction. So accurate measurement of RV volumes and function is critical in the clinical management of patients with acquired and congenital heart disease. And you would think that here at Stanford, otherwise known as the land of Tetralogy of Fallot and never-ending pulmonary artery reconstruction, we would be experts at imaging the right ventricle, but I am disappointed to report that we too struggle with its quantitative assessment. Just like everyone else, we try to assess this complex three-dimensional structure with its triangular appearance in the sagittal plane and crescent shape in the coronal plane by 2D techniques, where the RV inflow and outflow tracts are not even positioned in the same plane. So what we often end up doing, and I suspect many of you do too, is what we call the eyeball assessment. Maybe the RV is a little big, the free wall seems to come in okay, so function's probably normal. Here's our fearless leader, Dr. Leo Lopez, performing said eyeball exam. And obviously our ability to interpret echocardiograms improves the closer you sit to the screen, as Leo is demonstrating. And while we're on the subject of Dr. Lopez, as you all know, there are proposed standardized 2D RV size measurements obtained from the apical 4-chamber views and parasternal short axis views of the right ventricle. Here's a figure pulled from Leo's ACE guidelines paper in 2010, looking at the A, right ventricular basal and mid-cavitary diameters, and B, right ventricular length. But these measurements have limitations and do not correlate well with 3D volumes. So what else can we do to better quantify RV size by 2D, particularly in the postoperative TET population? Well, Dr. Raj Pun here at Stanford developed a novel measure called RV annular tilt, a surrogate for RV size in patients with repaired Tetralogy of Fallot. Drawing a line through the plane of the mitral annulus compared to the tricuspid annulus, if this angle was greater than 20 degrees, he found that it correlated to a RV end diastolic volume indexed by CMR of greater than 150 in our postoperative Tetralogy of Fallot cohort. What about RV systolic function by 2D? There's RV fractional area change, where you subtract the RV end systolic area from the end diastolic area and divide the difference by end diastolic area. In our lab, anything under 35% we consider to be abnormal. And we know that RV-FAC can correlate well with RV-EF calculated from cardiac MR. And in some disease states, such as pulmonary hypertension, the RV-FAC has important prognostic value. But what about specifically in Tetralogy of Fallot patients? The percent fractional area change does not include the contribution of the RV outflow tract to ejection. In our Tetralogy of Fallot patients with outflow tracts that are patched and dysfunctional, we have found that just using FAC will result in overestimation of global RV systolic function. So you can see in these studies of post-op TET patients that several patients with RV FACs greater than 40%, which would be normal by echo, had RV EFs by CMR of less than 40%. And the eyeball assessment of RV dysfunction on echocardiogram missed about 30% of patients who had some degree of RV dysfunction by CMR. We also have TAPSE, tricuspid annular plane systolic excursion, as a measure of RV systolic function. And we know that normal RV function is highly dependent on longitudinal shortening. TAPSE has been demonstrated to be highly reproducible. Normal values are available for children and is no doubt a useful quantitative parameter to serially assess RV longitudinal function in patients with right heart disease. At least in pulmonary hypertension patients, higher TAPSE values have been associated with greater survival. But TAPSE is a regional parameter used to measure longitudinal shortening in the lateral free wall of the RV. And these Tetralogy of Fallot patients with regional dysfunction of the outlet part of the right ventricle are not going to be captured. So in her paper investigating the use of TAPSE in patients with repaired Tetralogy of Fallot, Dr. Mercer Rosa writes, the ability of TAPSE to discriminate those with systolic dysfunction from those with preserved RV function was no better than chance. She concluded that TAPSE is not representative of global RV performance in Tetralogy of Fallot and may not be useful as a single measure of RV function in this patient population. So let's discuss more advanced 2D measures of RV systolic function, particularly strain imaging, which measures the degree of myocardial shortening or lengthening in the longitudinal direction for the RV. Strain and strain rate indices reflect myocardial performance and provide a more direct assessment of myocardial contractility compared to RV-EF. Moreover, as we've been discussing in this Tetralogy of Fallot population, quantifying both global and regional RV performance is important given the heterogeneity. And at least in pulmonary hypertension patients, deformation is frequently reduced in the apical segments and correlates to the severity of RV afterload, RV size, function, and clinical symptoms, such as reduced exercise capacity. So we recently sought to investigate the usefulness of 2D RV strain in a repaired Tetralogy of Fallot pulmonary atresia MAPCUS population, again, because we're Stanford, with residual lesions, attempting to see if regional performance was affected differently in different populations. And we in fact saw no difference in any of the segments captured by 2D strain among groups with conduit stenosis, distal PA stenosis, and conduit regurgitation, compared to Tetralogy of Fallot repairs with no residual lesions. But what we did find was that patients with conduit stenosis in particular had more adverse desynchrony, which meant a greater delay in time to peak systolic motion than those with distal PA stenoses or conduit regurgitation. So this may contribute to why we appreciate RV dysfunction sooner in those patients with conduit stenosis as opposed to regurgitation or even distal branch PA stenosis. And we can't discuss repaired Tetralogy of Fallot and RV function without discussing cardiac MR, which we appreciate as reference technique for RV size and calculation of ejection fraction. My partner in crime here this evening, Dr. DiLorenzo, will be talking all about the use of cardiac MR in Tetralogy of Fallot, so I certainly will not be spending any substantial time on this, aside from saying that other than size and providing quote unquote real numbers, tissue characterization techniques like late GAD enhancement have also been used to detect myocardial fibrosis in TET repair patients, with studies demonstrating that fibrosis is present not only in the surgically patched RV outflow tract, but also in the surrounding myocardial segments, and especially in the RV anterior wall in the region of the VSD patch. And as we know, fibrosis confers an increased risk of ventricular arrhythmia and leads to dysfunction. And while several of the proposed indications for pulmonary valve replacement in patients with repaired Tetralogy of Fallot rely on values obtained by cardiac MR, serial monitoring of progressive RV dilation by CMR in this population is 1, time-consuming, 2, expensive, and not to mention 3, not readily available for some institutions. And in fact, even at our own institution, cardiac MRs with anesthesia are generally only performed on one specific day of the week, and we share the magnet with radiology. And CMR is only reliable when adequately standardized. We know that measurement accuracy depends on the optimization of image acquisition and consistency in post-processing, including manual contouring, which is operator dependent. So what about 3D echo? Can we challenge the leading role of cardiac MR for RV functional assessment? There have been substantial improvements in 3D echocardiography for both valves and ventricles in the past years, with increasingly faster data acquisition times and offline analysis. But how does 3D echo compare to CMR? Well, many older studies found that 3D echo tended to underestimate RV volumes compared to CMR, particularly in the more dilated RVs of patients with significant pulmonary regurgitation, as much difference as up to 30%. But RVEF generally correlated well, suggesting that at least the size measurement errors were consistent through the cardiac cycle. So what else exists for us as we try to piece together quantitative echo data to aid in our clinical assessment? Well, this is a 4-year-old patient of mine with Tetralogy of Fallot, and Dr. Hanley performed a valve-sparing repair when he was 3 months old. He has since progressed to having moderate PR in the last year. So this is a look at longitudinal strain of his RV in 3D and 15 segments of the RV from base to apex, and circumferential strain of his RV in 3D in the same 15 segments. And these data were processed from 3D echo acquisitions from his scheduled surveillance echocardiogram. And we can also break down RV motion into only its longitudinal motion up top and anterior posterior motion on the bottom frame, and even its radial motion, which I didn't clip here. But what does this wealth of segmental data actually mean clinically? Well, we started with assessing pediatric PH patients first, and we discovered a few interesting things. 1, that pressure loading affects RV function primarily in the basal segments. Decreased radial and longitudinal motion may be characteristic of RV pressure overload. Anterior posterior motion, mainly attributable to LV contraction, may compensate for decreased radial and longitudinal motion to maintain overall global RVEF. And as expected, standard parameters referring only to longitudinal RV motion are inadequate to fully characterize RV function. So our group is currently partnering with Argus to look at repaired Tetralogy of Fallot patients as a cohort next, so more to come. So what are the next steps? Let's standardize getting 3D acquisitions of the RV in our echo protocols, particularly for our Tetralogy of Fallot patients. Let's use 3D echo to really understand the RV and CHD so we can optimize the care that we provide our patients. So thanks for joining me on this very brief tour of echo imaging of the RV. Thanks to the Society of Pediatric Echocardiography and particularly the Education Committee for inviting me to speak tonight, and of course to my Stanford Pediatric Echo Lab family, including Dr. Lopez, who provided a very generous picture in the earlier slides.
All right.
Thank you very much. We're going to head on to our next speaker, and then we'll do questions at the end. So I'm going to introduce Dr. DiLorenzo. He completed his categorical and non-invasive advanced imaging fellowship at the Children's Hospital of Philadelphia with a focus on echocardiography and cardiac MRI. He's currently assistant professor of pediatrics at Columbia University, Morgan Stanley Children's Hospital, and he's currently a member of the SOPE Career and Development Subcommittee. He's also immediate past chair of the SCMR Pediatric Early Career and Mentorship Subcommittee. He has a particular interest in myocardial mechanics and CMR markers of myocardial disease in children. Most of his research has focused on RV strain and Tetralogy of Fallot. And he's currently also the PI of a large multi-center study assessing normal values of markers of diffuse fibrosis in children and adolescents. So with that, here is Dr. DiLorenzo with his talk on Tetralogy of Fallot and CMR.
Okay, thank you, Jenna. Good to see you again. Just gonna share my screen. Okay, so I have the tall task of talking about echo versus MRI and Tetralogy of Fallot. My main disclosure is that I do and love both echo and CMR, and like Lucille Bluth, I really do not play favorites when it comes to my imaging modalities. So I will say that this is a great resource for imaging in Tetralogy of Fallot. Emery Valente and others published this guidelines, which is really helpful for imaging and gives a lot of information about all the modalities. First thing to keep in mind is that MR versus echo is not a competition, despite the fact that so much data out there talks about echo versus MRI. They're really complementary, and each contributes to the greater puzzle of myocardial health. And whereas echo remains a workhorse, CMR is really helpful if more data is needed. So first, let's consider the technical considerations. Here, I think echo is the true winner. Time, it tends to be shorter, though maybe less so now that we do all these advanced modalities and techniques. It tends to be cheaper, though that depends where you are. More accessible, whereas CMR tends to be at big hospitals or academic centers. You can perform echo with motion. There's less artifact disruption, and there are no contraindications that I know of. So in summary, echo is more readily available at most ages and disease states. And the decision to perform a CMR, you really need to think if it's going to be useful. So as has already been discussed, the limitations of echo are the poor windows, the anterior location, abnormal RV geometry, patient motion, which really makes a difference for stitch artifact for 3D imaging. And then the other important consideration is differential. My videos aren't coming through. Unfortunately, my videos aren't coming through right now, but it showed a 4-chamber view, which showed reasonable function in the RV in short axis where there is hypokinesis of the RV outflow tract. And it's important to keep in mind that the 4-chamber view only gets that one piece and misses out on the RV outflow. For CMR, the limitations are numerous. There's a lot of artifact due to ferromagnetic materials. So this is an example of a patient with coils in the rima and lima. Stents, mechanical valve, especially stainless steel coils create a decent amount of artifact, and there are ways to compensate, but they're not 100%. And this is especially problematic when you're dealing with the anterior RV, especially with sternal wires. You also need a patient that's still. One thing to keep in mind is that CMR is not a real-time imaging modality. It takes portions of an image from each part of the heartbeat over numerous heartbeats and then averages them into one. So if you have any sort of abnormal motion, claustrophobia, or abnormal motion or arrhythmias, that's really going to throw off your results. So we typically need sedation for claustrophobia or young age and medical suppression of arrhythmias. There are contraindications as well, whereas pacemakers were typically a large contraindication. It's probably less so now when we tend to be imaging more patients with even non-conditional pacemakers. Vagal nerve stimulators and cochlear implants are still contraindications, and then contrast is contraindicated when you have renal failure. So I'm just going to try this one more time because for some reason my videos aren't coming up. Still not. So if it's okay, I'm going to play it in this view so that the videos do come up. So then the question is, when do we do CMR? Well, really, I think we do under 10 if there's a good reason. So you need sedation, because you need sedation. So really, if you have symptoms such as right heart failure, exercise intolerance, significant RV dilation by echo, anatomical questions, concern for residual shunts to calculate QP to QS, or poor echo visualization. And in adolescence, it really becomes a routine examination. So these are the recommendations for MR. Pretty much under 10, it's really as needed. Over 10, about every 3 years for a stable patient, and then every 12 months if there's significant RV dilation, progressive dilation, or significant dysfunction. Next, we'll come to the anatomic and functional parts. And for this, I'm really going to concentrate on ventricular size and function, systolic and diastolic, where they tend to be a little bit more even. So why is CMR generally considered better for function? Well, first of all, it's considered the gold standard for volumes in EF. Volumes are frequently cited as well as function for an indication for PVR, but there are limitations to this. First of all, when you're dealing with obesity or higher BSAs, how can you accurately index when the BSA is elevated to begin with? So a lot of people sometimes use the RV to LV and diastolic volume ratio of greater than 2 to make their decisions about PVR. But what do you do when the LV is dilated, like we frequently see in Tetralogy of Fallot? And then finally, what Z-scores are you using? We know that the Z-scores tend to favor adolescents and older children. And so the accuracy of Z-scores at the younger age group is not great. Next, the way we assess ventricular function by CMR is that we perform a short axis stack. We take 10 to 12 slices in a short axis plane. We, in those slices, we measure the end, measure it end diastole and end systole, and together that allows us to calculate an EF. But one thing to keep in mind is there will be variability. First, how do you contour? These are two different methods of contouring. Up top is the traditional one in which papillaries and trabeculations are included in the volumes. And at the bottom is a more newer technique where trabeculations and papillaries are excluded. And what's been shown in the data is that can actually result in significant differences on the order of about 20 cc's or about 4% for EF. So that can result in significant variability. Next, where you contour makes a difference. So if you were to see my images, you would see that the basal slice, if you tend to exclude the basal slice, you're going to miss volume. The other question always comes up of where do you contour the pulmonary valve? When you have RV outflow patches and transalveolar patches, what do you choose to end your ventricle? And similarly, the AV valve, what do you include in the ventricle versus in the atrium? And that always causes a little bit of variability. Next, who's contouring makes a difference. So a lot of studies where you look at one person, two people contouring one heart, one study will show that they have excellent reliability. But what happens when you take multiple studies like we deal with in most patients that have multiple studies over years? Well, here we find that there is actually significant bias and there will be variability up to 4% ejection fraction. This is especially true when you're dealing with 4 or greater studies. So in this, they looked at RV-EDV, indexed RV-EDV over patients that had 4 or more studies. And you can see here that the variability is up to 10 to 15 cc's per meter squared, which is quite huge and can make a huge difference in your clinical decision-making. For echo, as was already mentioned, there are multiple ways to look: the qualitative method, fractional area change, TAPSE, isovolumic acceleration, tissue Doppler, S prime strain, 3DEF. And the variability, when you look at the variability for function, it's actually quite, the reproducibility is quite reasonable. So if we look at 3D echo, and this was a study where they looked at 2 modes of 3D echo for fractional area change and MRI, and found that there was overall excellent interreader and intra-reader variability. And that, as already mentioned, the 3D MR tended to represent EDV, and fractional area change overrepresented EDV, but for EF, they tend to be pretty good. Finally, RV strain tends to have overall good reproducibility, both inter and intra-reader. But the one issue is that inter-vendor variability still remains poor. So there's a big difference depending on what vendor you're using. I'm going to touch briefly on diastology. I will say that diastology is not MRI's strong point. There are ways that you can do phase contrast imaging of the inflows, tricuspid and mitral, to get an E and an A, or you can do low velocity, essentially tissue Dopplers of the tricuspid or mitral annuli. But why would you do that when you have echo that's perfectly good and better image quality? By echo, though, diastology is still an issue. So traditionally, end diastolic forward flow, in which you get a forward flow during end diastole across the pulmonary valve, was considered a representative of restrictive RV physiology. But over time, studies have again and again borne out that it's associated with more PR and larger RV volumes rather than smaller ones. So it's probably not the diastolic modality that we really think, or thing that we think it is. Tricuspid inflows and tissue Dopplers, ACE recommends this as the mode to assess diastolic RV function in adults. But we've looked at this and looked at various stages of diastolic dysfunction compared to EDP and found that there's really no association. Right atrial size and IVC size are reasonable methods to assess for diastology. I really think diastolic strain, so early and late diastole, and atrial strain are going to be the big way that we assess diastolic function, but they're still kind of research use tools and hard to use clinically. Just a couple of extra things on CMR. So RV strain, we can do RV strain by CMR. It's feature tracking imaging, and where you see the differentiation between the myocardium and blood pool. Because of the high resolution, you do get good differentiation and it tracks better, and you can easily do multiple imaging planes, but there are limitations. The images are average, as I mentioned, and so you get worse temporal resolution with frame rates in the 20s. You have variable reproducibility, especially between software vendors, and there's a lot of variability between CMR and echo strain. But it has been associated with EF, prior interventions, and peak VO2 or peak power. Finally, delayed enhancement imaging. Typical areas of delayed enhancement include the VSD patch, RVOT patch, insertion points, so at the inferior and superior insertion points. And it tends to be associated with decreased exercise tolerance, arrhythmias, RV dysfunction, higher RV volumes. A more novel technique is T1 mapping. This has interstitial or diffuse fibrosis. The problem here with tetralogy is due to the thin wall nature of the RV, it's really hard to get RV T1 mapping values. And finally, for echo, I think there's a 3D imaging is the way for the future, especially when you're looking at AV valve anatomy and assessment, and also rotational mechanics. So as we know, the base and the apex of the LV move in a ringing motion with opposite directionality. It's been shown to be decreased in Tetralogy of Fallot and associated with this decreased function, and it tends to be more pronounced in patients that actually don't have RV dilation. So in summary, the question is echo versus MRI. On the one hand, you have echo, which is easily usable and readily available, better for visualizing mechanisms of regurgitation or shunts, better for valve anatomy, and good for systolic function, still questionable for diastology, versus MRI, which is less readily available, but has higher resolution, is still the gold standard for EF. You can quantify flows and shunts, and you can perform tissue characterization. So the answer is both. I think both of them really have a huge place in our field and should be considered complementary. So thank you very much for inviting me and for listening to my talk. And I apologize again for my videos.
All right, we'd like to thank both of our speakers, and we're going to go ahead and start answering some of these questions. The first one we have is from Rosanna Frazier. She asks, if you're using RV strain, what numbers do you consider normal in your lab? And I guess to expand on that question a little bit more, these more advanced echo techniques, which of them are we using consistently in our labs, and which are more in the research phase?
I would say, at least in our echo lab, we're trying to be a lot better about 3D RV echo acquisitions and 2D RV global longitudinal strain. We have not set a standard value in our lab that says, oh, if it's anything below, the minus mid-20s, we'll call that normal. I would say in my own personal practice, I would say if it's like minus 24% and anything better than that, I'd say, yeah, that's a pretty solid normal global RV longitudinal strain. But I find myself using 2D RV strain a lot more in comparison between populations. To seeing if one cohort is decreased compared to another cohort. I find myself doing that a lot more than just looking at the 2D RV global longitudinal strain value in isolation. If that makes any sense. Michael, are you doing anything differently?
No, I will say that Jenna can speak to what we found as normal in our study, and it tended to be in the minus 20s, mid minus 20s, but typically we still do a lot of eyeball method. And more than anything, fractional area change, especially pulmonary hypertension. And then in that group, we'll also do TAPSE.
Yeah, it was around the mid minus 20s. That was in our normal group. So.
Can I add a quick question, really, just to follow up to that? Are you guys consistently doing 3D echo for everybody?
I wish. I think we are. We're definitely. I would say in the last year, we're getting a lot better at it. And we're doing what we'd like to do is make sure that it's included in every study, normal and abnormal. But what we are making a good effort for are the ones where truly there's RV disease, pulmonary hypertension, Tetralogy of Fallot. What we'd like to do is be able to get those acquisitions in all normals and all abnormals, especially as we get quicker.
All right, there's another question from the chat asking how reliable is the functional measurement, function and volume of the right ventricle with cardiac tomography if we do not have cardiac resonance?
If you don't have cardiac resonance?
Resonance, yeah.
Oh, CM. Okay, so CT if you don't have CMR. Got it.
Yeah.
Yeah, so we typically here don't do as much CT, though data has shown that it tends to be reasonable. The problem with CT as compared to CMR is that you won't get the same level temporal resolution that you can get with CMR. So you're going to have fewer phases for the cardiac cycle, and that may throw off your volumes a little bit. But especially when you're doing scanning of both systole and diastole, you can get reasonable assessments of volume and function.
There is another question. Do you think 3D RV accurately assesses the outflow tract in patients with tetralogy or other dilated RVs?
I think what we have found is that 3D size metrics are good. A lot of it is because we're able to get a lot of these images from subcostal imaging. But I have noticed that in the older patients where their windows are very challenging, that 3D RV is much more challenging to obtain. But at least in children, it's been reasonably reliable and pretty comparative with the values that we're getting off of CMR.
All right. Do you see any other questions, Jenna, I don't see any more in the chat box.
Yep, I think we've answered everybody's questions.
All right. Thank you so much for presenting today at our SPEED webinar. Thank you to the audience for being here and for the questions. Our next SPEED webinar would be on coronary imaging on May 23rd. And we'd be excited to see you all back here.
Thank you.
Bye. Thank you.
Thank you.
Thanks to our speakers.